Greetings! What you're seeing here on the animation is a pneumothorax developing. I started with it because I painstakingly drew and animated this for 3 entire days and didn't want to risk jumping off the video before seeing it. Jokes aside, it was fun, but I'm a physician, not a graphic designer. So, now that you've got your attention, if you have 10 minutes, I'd like to explain what you're seeing right now. If you ask a child how the lung inflates, she's going to answer it increases in size because it's being filled with air. However, that's exactly the inverse of what actually happens. The lungs get filled with air because they have increased in size, not the other way around. The diaphragm and the chest wall muscles pull the lungs outwards, causing them to enlarge. This larger volume means the air molecules that were already inside the lungs are now more spread apart, aka the pressure is lower. Increased volume, same amount of molecules, lower pressure. Since the pressure inside the lungs has gone down, it's now lower than the atmospheric pressure, and air from the environment flows through the airways into the lungs. Once gas exchange has occurred, the respiratory muscles relaxes, causing the lungs to collapse and pushing the air outwards due to increased pressure. Except neither the diaphragm nor other inspiratory muscles insert directly into the lungs. There are two layers of serous membranes, the pleura, between the lung parenchyma and the chest wall, diaphragm or mediastinum. The layer directly overlaying the lung parenchyma is called the visceral pleura, whereas the one covering the inside of the chest wall is called the parietal pleura. Since there is virtually no space or pressure between these two layers, pulling on the parietal pleura usually causes the visceral pleura to come along and vice versa. We often say that the pressure in the pleural space between the visceral and parietal pleura is negative. This is of course in relative terms. It only means that it's lower than the atmospheric pressure and thus can be interpreted as vacuum for practical purposes. What happens though if we insert air into the pleural space, if we destroy this vacuum? Then forces exerted on the parietal pleura will no longer transfer to the visceral one. The chest wall and the diaphragm will pull the parietal pleura outwards. However, instead of bringing the visceral pleura along and by extension the lungs, the parietal pleura will simply distance itself from the visceral one while air fills the space. Can you see how this renders the respiratory movements useless since the chest wall keeps expanding but the lungs no longer accompany it? So, what name would you give to a condition in which there is air inside the thorax but outside the lungs? I don't know, but someone thought a good idea to call it a pneumothorax. In summary, pneumothorax is the accumulation of air in the pleural cavity as a result of disease or injury, impairing lung expansion due to changes in the pressure gradient. And speaking of disease or injury, there are basically two ways air can get into the pleural space: from inwards or from outwards. If you get stabbed in the chest, a communication is formed between the environment and your pleural space, and air from outside your body can now flow into the pleural space. On the other hand, if you have a lung disease that causes bullae to form on your lung surface, for example, this air bullae can rupture and leak air into the pleural space from the inside. Then you will be communicating the pleural space with the airways. Either way, air should be inside your lungs, not around them. Air around the lungs prevents the lungs from expanding, and if the lungs don't expand, air doesn't come inside, and there is no gas exchange. Naturally, pneumothorax is usually unilateral, so you still have the other lung to breathe with. Therefore, death is usually due to compression of adjacent structures. We will get into that. On this figure, we see a left pneumothorax quickly developing due to some leakage of air from within the lung to the pleural space. This could be a bronchopleural fistula or a ruptured bullet, for example. In this particular case, we are observing a specific type of pneumothorax, where the lesion works as the exact opposite of a three-sided occlusive dressing, allowing air to pass into the pleural space during inspiration, but preventing it from exiting during expiration, blocking its way outwards, its outward flow during expiration. This is called a tension pneumothorax because air will accumulate inside the pleural space, progressively increasing the pressure and pushing adjacent mediastinal structures. This is considered an emergency since the compression of the great vessels risks an obstructive shock and poses severe risk to life. In the image, you can see that with each inspiration, more air leaks from within the lungs to the pleural space. The space between the pleural layers is usually virtual, meaning, though by no means glued together, the two layers of the pleura are very close, as if there was no space at all. By looking over the normal lung, the right one here, you notice that the pleura looks like a single membrane. You cannot easily distinguish the two layers. On the left lung, on the other hand, air leaking in between the pleural layers is causing them to separate, and the space becomes more and more visible as it enlarges. Eventually, you can clearly see the visceral layer over the lung, a lot of air in between, and the parietal layer overlaying the inside of the chest. Meanwhile, when the chest expands, pulling with it the parietal layer, air flows into the pleural space and prevents its pressure from dropping significantly. With a higher and higher infrathoracic pressure, atmospheric pressure is no longer high enough to cause an inward flow into the affected lung during inspiration. Remember, flow derives from a pressure difference. A pressure difference we are losing. Hence, the lung progressively collapses and is no longer inflated. Even worse, if the lesion is such that it works like a valve and allows air into the pleural space but not out of it, the pleural pressure will rise not only until it equalizes with the atmospheric pressure, but simply higher and higher and higher and higher. And this giant sac of air formed inside the chest may start compressing and displacing adjacent structures, such as the heart and the great vessels. This is usually the cause of death. Diagnosis is usually easy because you have no lung sounds on the pneumothorax side. Since the lungs collapse, auscultation will be silent. Resonance, however, will be increased since there are lots of air in the involved hemithorax, just not inside the lung. Chest X-ray will show a hyperlucent field where the collapsed lung should be, no lung markings on the periphery, and the silhouette of the collapsed lung. If it's a tension pneumothorax, there may also already be tracheal and mediastinal dislocation away from the lesion, but then maybe you don't even send the patient to imaging studies. So, how do we treat pneumothorax? Well, the simplified answer couldn't be more intuitive. Remove the air from the pleural space. If it's an emergency, if we're dealing with a tension pneumothorax, a needle aspiration may be necessary immediately to relieve the pressure. That said, definitive air removal is going to be done through the insertion of a chest tube. With the chest tube positioned correctly, it will allow air to be pushed out of the pleural space during expiration, but will prevent its return when the chest wall expands. Of course, solving the cause may also be necessary. If the pneumothorax originated from the ruptured air bulla, there may be no active leak, and just placing the chest tube may be enough. If you have a penetrating chest trauma such as a stab or an air fistula, for example, surgically correcting these lesions will be paramount to stopping air leakage into the pleural space. Thank you for watching this video. If I ever delve deeper into pneumothorax, I'll make sure to link the following video here. And if you're interested in medical lectures, make sure to check my playlists on it, such as congenital heart diseases or OBGYN. I also have some USMLE-like question resolutions if you're interested in practicing your knowledge. And if you speak Portuguese, make sure to check my Portuguese spoken channel. Thank you for choosing to share your time with me, and I hope to see you on the next video.